Good evening, and thank you for joining us for the Endometriosis and Pelvic Pain webinar tonight. My name is Elise King, and I'm part of the Population Health team at Central and Eastern Sydney PHN. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. And I'd also like to extend that respect to any Aboriginal colleagues who may be joining us tonight. So this webinar is being recorded and will be available on the Suspin YouTube channel in the coming week. At the end of the webinar, an evaluation survey will pop up in your web browser and will be sent in a follow-up email tomorrow. We appreciate your feedback. Please complete this evaluation to allow us to issue your certificates of attendance. We'll be using the Q&A function this evening. Please enter your questions into the Q&A icon at the bottom of your screen. The Q&A session will follow the presentations. Tonight's event has been RACGP accredited for 2 hours of education activity and 1 hour of reviewing performance activity. A post-activity will be sent out to you after the session. We will submit your CPD activity hours that you have completed with RACGP on your behalf. And here are some upcoming events, so please visit the Suspin website for more information and to register. So before we start, I'd like to introduce Dr. Martina Gleeson, a GP and clinical lead for South Eastern Sydney Local Health Pathways and the Regional Clinical Advisor for Health Pathways New South Wales, who's going to do a short Health Pathways update.
You got my slides? Sorry, Elise, have you got my slides or Lauren?
I think Lauren's getting them up. Yeah.
Thank you very much, everybody. This is really here to remind you where you can go back and find more information to reinforce your learning after tonight's webinar, and where you can find referral resources in our local area if you need them. CESFAN supports 2 Health Pathways team, one for the Sydney Local Health District and one for the South Eastern Sydney Local Health District. If you could advance the slide, please. So there are the QR codes for them. If you've never used Health Pathways before, you can shine that on your phone and it'll open up the site. We can give you login details available on request. And you can use, if you've got login details for one of the Health Pathways sites, you can use it for the other in the CESFAN region. Next slide, please. And we suggest that you use the site that is going to serve where your patient is going to be referred, if they're going to be referred, so or accessing services. So if your patient's going to go to RPA to access services, use the Sydney website. If they're going to go to the Royal Hospital for Women or St George or Sutherland or Prince of Wales, then use the South Eastern Sydney site. Next slide. Just to let you know how to do a search, there's a search bar right up the top of the site that you can type in your search. So, for example, osteoporosis, and then you select the pathway that is given to you in a menu. And then when you open up, if you're looking for something specific on the pathway, if you click Expand All and then Control F and type in your search term, so maybe you're searching for denosumab, then when you press enter in the Control F bar, it will highlight where you can find that information in the pathway. Next slide. Also, if you're finding a service, you can actually click, if you know the name of the service, so for example, Get Healthy, New South Wales, if you search for that, it will show you all the pathways where we've listed that service. Next slide, please. And you can use Health Pathways to get your educational activities and also your reviewing performance using QuickLog. So if you use a Health Pathway to look something up and then you use that to adjust on your like what you're doing for the patient, and you do a little reflection, you can QuickLog that for hours towards your CPD. And we recommend that you take a screenshot or use a hyperlink in your QuickLog so that you can justify what you did. Next slide, please. So the health pathways on Southeastern Sydney for women's health include clinical pathways on endometriosis, cervical screening, persistent pelvic pain, and we have menopause in draft. And we have requested resource pages for gynaecological assessment, both acute, that's an emergency, and non-acute, which is not emergency, where to call for gynecology advice, colposcopy, and IVF requests. And we just want to let you know that Sutherland Hospital is now using e-referral. So if you want to refer to Sutherland Hospital outpatients departments, you can use HealthLink in your clinical software, and you can find the e-request forms in your clinical software. And Royal Hospital for Women is coming soon. Next slide. Sydney Community Health Pathways has these pathways listed, and service information for Balmain, Canterbury, Concord and RPA Hospital and Community Services. Next slide, please. And they're the contact details for our teams. I think that's my last slide. Thank you, everybody. I'm looking forward to hearing from Rebecca and Joanna.
Great, thanks, Martina. So I would like to introduce today's speakers, Dr. Joanna Lynn and Dr. Rebecca South. Dr. Joanna Lynn is a GP at Leichhardt General Practice and Inner West Women's Health. She enjoys caring for both men and women of all ages, but has particular interests in the care of women and children and fertility. In addition to having FRA CGP, Dr. Lynn has completed a Diploma of Child Health and a Masters of Reproductive Health and Human Genetics. Dr. Rebecca South is a GP from Leichhardt General Practice. With a strong interest in sexual and reproductive health, Dr. South worked for many years at Ashfield Family Planning New South Wales Clinic. Dr. South is a GP advisor for the RPA and Canterbury Hospital Antenatal Shared Care Program. So I'll hand over to Dr. Jo now.
Thank you. Hopefully everyone can see my screen. Thanks, Elise and Lauren. So my name's Joanna, and yes, so we're here tonight to talk about endometriosis and pelvic pain, and we've given it the title, It's Not as Scary as It Sounds, because I used to think it sounded really scary. Let's have a look. This works. So we know that endometriosis affects about somewhere between 1 in 8 or 1 in 9 women in Australia. And in 2021, that was over 830,000 women. In 2018, Australia was the first country to develop a national roadmap, as they called it, for trying to tackle endometriosis. And they involved government bodies, academics, and advocacy groups. They noticed that the recognition of endometriosis, that it's actually a chronic disease, then that it was under-recognized and under-researched and underfunded. So the aims of the National Action Plan are to improve awareness and understanding of endo, reduce the time to diagnosis, and to try and develop better treatment options and work towards a cure. And in part of their action plan in 2023, they announced that there were going to be 20 clinics set up as endometriosis and pelvic pain clinics around Australia. And our clinic was one of them. There are now 22 clinics, and these clinics they're functioning between July 2023 and June 2026. We know that it's such a chronic condition and has a heavy financial burden on both patients and the healthcare system. They estimated that there are about 24,000 hospital admissions each year relating to endometriosis. So let's just recap what endometriosis is. It's an inflammatory condition where there are lesions of uterine-like tissue outside of the uterus. And yeah, the incidence is somewhere between 1 in 8, some places say 1 in 7, 1 in 9, somewhere in that realm, but definitely common. We also know that if you have a first-degree relative that has endo, that your chances of having endo are really increased, and it's about 10 times the risk. And for a long time, it was common to just reflexively refer these women that we thought had endometriosis to a gynecologist. Mainly because a lot of us were taught when we were in medical school and as junior doctors that these women needed a laparoscopy to get their diagnosis. But things have really shifted. We now are trying to emphasize that it's about treating women with suspected endometriosis so that we can prevent complications and prevent the progression of endometriosis into chronic pelvic pain. There's a lot more understanding about endo now, and what makes it so tricky to diagnose is that, you know, I've included a list of symptoms there, and they're certainly not all of them, but they're just so varied, and there's just a wide spectrum of disease symptoms and disease severity. So this is probably less relevant to day-to-day general practice, but what I wanted to point out with this is that there isn't actually enough understanding about how endometriosis develops. It's been long thought that retrograde menstruation was involved, but that, I guess, didn't really explain why there was such a strong family history risk factor. I think there are, as you can see in the diagram, you know, they now think that maybe there's something in the embryo that happens that predisposes them. Perhaps there's a link with chronic inflammation or some sort of environmental exposure. There's still a lot to learn, and hopefully with extra funding, we are going to learn more. Now, what's pretty shocking is that even in Australia, where we have a really great healthcare system, the average time to diagnosis is 7 years, and in some countries it's worse than that. Part of that is because, you know, a lot of young people grow up thinking that period pain is normal. Another thing is that, you know, the symptoms are really hard to pinpoint sometimes. You know, people think that they have IBS, but actually it's endometriosis on their bowel. Or they may have, you know, bladder symptoms that they just think is recurrent UTI, but actually that could be a lesion of endo on their bladder. Often you'll find that physical examination doesn't reveal anything. There's not a lot to see. You can't actually see endo. And for a long time, the focus was on getting a histological tissue diagnosis. So laparoscopy was required to make the diagnosis. We also know that, you know, a negative ultrasound doesn't exclude endo, and that's unless there's a chocolate cyst perhaps on the ultrasound, it's really hard to see endo on ultrasound. The lesions are often too thin to be seen. Some of you may know that MRI is emerging as a useful technology, and there are definitely some groups around doing MRIs of the pelvis to try and diagnose endo. But that's, you know, still being developed and probably going to be used more in the future, but not yet. And then the other issue with endo that makes it hard to diagnose is there is no blood test or biomarker that we can use to diagnose it or monitor it. So interestingly, and I think we've all seen this in our patients, some women can have a lot of lesions when they have their laparoscopy, but have very little pain. And then there will be women who have terrible pelvic pain, and when they go to laparoscopy, have not a lot to see or very few lesions. So I guess a good kind of progression now is to think of, a lot of women have endo, and if they have chronic endo for long enough, it actually leads them to develop what gets termed chronic pelvic pain or persistent pelvic pain. The Royal College of Obstetricians and Gynaecologists defined that as intermittent or constant pain arising from the lower abdominal pelvis of a woman of at least 6 months duration and is not exclusively associated with menstruation or intercourse and not associated with pregnancy. There is usually more than just one process happening in chronic pelvic pain. There's the pain from the pelvic organs, and that could be the uterus if it's endo, or it could be the bladder, could be the bowel. There's the pain from the musculoskeletal response to the pelvic organ pain. And that I've actually found, and I think Rebecca would agree with me, that actually has really changed how I approach these women with pelvic pain. There's also the process of central sensitization. And lastly, but very important still, the psychosocial impact of pain. Now, for women who end up getting chronic pelvic pain or persistent pelvic pain, dysmenorrhea and dyspareunia are really significant risk factors. So if women are having those symptoms early on and when they're younger, they have a high chance, I don't know the exact numbers, of actually progressing to getting chronic pelvic pain. So we really should see, when we see these patients in practice, that that's an opportunity for early intervention to teach them how to treat their pain, and maybe to prevent them from progressing to chronic pelvic pain. So this table is to really just confuse everyone, perhaps. It's divided what are possible causes of pelvic pain in women. And as you can see, there are a lot of possible causes. And one really big challenge with chronic pelvic pain is that there's a lot of overlap. There will often be more than one process happening. The woman could have endo and adenomyosis, and she may have some irritable bowel syndrome from her endo affecting her bowel. She could have, muscle spasm in her pelvic floor muscles because her endo has been so chronic that her muscles are all switched on and tense. There can be issues in their mental health because they've spent so long dealing with pain, or they've missed out on things in their life, which has led them to be anxious and possibly have depression as well. So there is, it is a big picture thing that you have to, look at them with a big picture to try and work out what's adding to their pain and what's causing their pain. Chronic pelvic pain is thought to account for about 20% of presentations in outpatient gynae clinics. So it is really prevalent and it's chronic, so they keep coming back, and there's a lot of difficulty managing their cases. We know that getting a diagnosis and treating their pelvic pain is really involved, and it's actually quite a lengthy process. But that's where general practice is really well placed for doing this. We are more available, I guess, than a gynae outpatient clinic, and we can develop a good relationship with these people and follow them up. So yeah, I do think in general practice, we could really do a lot more to help people with chronic pelvic pain. In the final column, you'll see in the psychological column, there's a history of sexual abuse. And that actually is quite significant in increasing your risk of getting chronic pelvic pain. It's estimated that there's about a 5 times increased risk of having chronic pelvic pain if you've had previous sexual abuse. So it is important to face these patients with a trauma-informed view. So I just said it was really hard to diagnose and really lengthy. But what we're hoping tonight that you'll get from this talk is that it isn't as scary as it sounds. What I found really helpful in this process is actually expanding my knowledge about pain science and the new developments of pain science, because I guess if we can understand the pain and why people were having pain more, then maybe we can target our treatments better. So getting back to basics again, what is pain? So pain is a sensory and emotional experience associated with an actual or potential tissue damage. So there are three recognized groups of pain. There's nociceptive pain, which is, as we all know, tissue damage. You pull a muscle when you went for a run and you get pain from that. There's neuropathic pain. So that's pain that arises from the damage of nerves. We all know that lady. And then the newer type of pain, and the hardest one to probably get your head around, is this idea of nociplastic pain. So that's pain that arises from altered nociception, so change in how you perceive the pain, despite no clear evidence that there's actually been any tissue damage or any threatened tissue damage. And that's where all these chronic pain syndromes probably sit in. So this plasticity of our nervous system is what's believed to cause the progression from acute pain to chronic pain. We now know, well, actually, let's go back. We used to think, in the Cartesian times, if you look at this diagram, that we used to think there was only an ascending process or a bottom-up process for pain. You'd hurt yourself on something, you'd tell your brain, ouch. What is now recognized, though, is that in addition to that, we have descending modulation. So we can, other things outside of that affect how we perceive and receive that pain. So, your prior experiences of pain, maybe if you're distracted, you're not going to feel the pain as much. If you're if you've got terrible depression or anxiety, we all know we don't cope as well when our mood is not good. And the really, really important thing is this idea of sensitization. So what is sensitization? So that occurs, as I said, from plasticity, which makes acute pain become chronic. So chronic pain occurs because of neuronal changes. So the neurons are actually alive and changing, and that leads to a heightened response to what you used to think wasn't a bad stimulus. Peripheral sensitization is where there's an inflammatory response by the immune system, and that damage results in changes to your nociceptors peripherally. Central sensitization is where the nerves of your central nervous system start to generate action potentials and be stimulated when there really isn't anything there to stimulate it. And this leads to the inappropriate transmission to the brain that we've got pain. So having sensitization actually makes your nervous system more sensitive to stimuli, and it's this process that leads to that chronic, widespread, migrating regional pain and hyper-responsiveness. And it makes you tired. So these patients have got fatigue. The three features of central sensitization are hyperalgesia, so that's being overly sensitive, allodynia, which is where something that was previously not painful to you becomes painful, and then this global hyper-responsiveness. So this idea where, a smell that you associated with an experience actually starts to stimulate pain in you. So sensitization is actually there to amplify pain. And something that I don't know if everyone knew this. This was new to me when I learned this recently with all this endo, was that we actually need to stop doing too many laparoscopies in these patients. Every laparoscopy worsens sensitization. So a lot of patients who've had a lot of laparoscopies, a lot of them will come back and say to you, I think I need to go back to the gynae. I think my endo's back. And they think that going back in to clean up their endo is going to make them feel better. But actually, each one of those operations sensitizes them and makes their nerves more switched on to pain. So, how do we actually treat these patients with chronic pain? I just wanted to show a slideshow from a group that are called Retrain Pain. And it's an analogy that might be helpful in understanding sensitization and how we can treat it. So hopefully this works. I'm going to switch my screen. Okay, so this is just I'll get everyone to read through it. I'll try not to be too quick, and I'll be quiet while everyone's reading. So I find that really helpful and a really good reminder of what we need to do to help patients with chronic pain. Just bring back my slides. So yeah, a lot of people who have persistent pelvic pain or chronic pain, and this is just not pelvic pain, anyone with chronic pain, they actually need to be retrained and learn to try things even with pain. So here we go. It's really important when, as with a lot of things in medicine, to approach this with the biopsychosocial approach. So you've got to consider what's happening to the person's body. So what are the processes of disease in their body? Understand what's happening in their mind, and because that's going to affect how they cope with pain. And also start to know what's happening in their life. Are they struggling with holding down a job? Have they recently separated from a partner? Have they not got enough money to pay for their medications? All of those things will feed into their pain experience. So we really do need to look at patients with the big picture view. I thought I'd share this. I really like this handout, and it's available free. It's from a group called Curable, and they've got an app, which I have no association with, but I really like how they explain chronic pain to patients. And I will point out probably from about, path 6 and 7 onwards, if you've got these patients who have chronic pain, they have got sensitization from these learned neural pathways, and then they are just feeling really low and like there's no hope. But what we can do is really educate them with pain science, so letting them understand what's actually going on in their body, reassuring them, hopefully, that there's nothing that's really, really serious happening in their body, and then getting them to try new things and teach their body that they can do things and that they can get on with their life. And a lot of that actually doesn't involve medication. So what's really important, I think, with patients with endo, patients with chronic pelvic pain, is actually to spend time with them. A lot of them have been to lots of doctors already. They've seen specialists, they've seen pain specialists, they've seen naturopaths, they've seen acupuncturists. They have been looking for an answer for a long time. And what is really therapeutic is actually giving them time to just tell you their story. So in our clinic, with our first appointment with these patients, we actually get them to book a 45-minute appointment so that we don't feel rushed and that we can give them time. And it really does work that if you just let them talk, they feel better. So yeah, listen to them is a really important message. And teach them about chronic pain and pain science, and explain to them why they're having pain outside of their period, for instance. And there are some e-resources that you can refer them to, and I'm just listing a few here. The one at the end there, Explain Pain, that's actually one that patients can do too, but there's a really good course for clinicians to do. And everyone who's been involved in the endo pelvic pain clinics who've done this course say it's the best course they've ever done in regards to pain. I do plan on doing it. I haven't done it yet. But they've recently put out a self-directed web learning. So that used to be you had to actually attend these courses for a whole weekend, but they've now done recording so that you can work through the material at your own pace. Actually get help with treating these patients. You're not going to be able to do everything yourself. Multidisciplinary care is essential in managing patients with chronic pelvic pain. There's not going to be one thing that's going to resolve their pain. So a good pelvic physio is essential. Often a psychologist is really beneficial because, it helps them maybe treat their anxiety, and that will make them cope better with the flares of their pain. Maybe an EP, an exercise physiologist, to try and get them more active and moving. A big message is to get them moving. That would be really simple things like walking. That's free. Regular low to medium intensity exercise reduces the muscle spasm that they are experiencing. Another important thing is to treat any comorbid pain conditions they have. So a lot of people with endo often have migraine too with it. So making sure that you treat their migraine well. Prevent or treat constipation, because you know, being bloated and having distension of the bowel is going to exacerbate their pain as well. Get them to try and reduce stress in their life. And that might be, you know, doing some deep breathing and meditation, or actually just changing some things in their life, you know, saying no to things and reorganizing a few things so that they feel less stress. As their GP, help them develop a plan for managing their flares. You know, they will get flares of their pain, but if they feel equipped and have a plan on how to handle it, their pain won't be as bad. And of course, there's always medication. And in the case of endometriosis, that would be hormone suppression, which Dr. South, I'm sure, will get into. So yeah, my last slide really, actually, it says that chronic pelvic pain is not just endometriosis. It's a whole lot of other things as well. But a lot of it is. So there's at least 70% of patients with chronic pelvic pain, or female patients with chronic pelvic pain, that will have endometriosis as well. So this is where I hand over to Rebecca, who can take us through that.
Hi. Well, thanks so much, Jo. I mean, Jo and I have been working together on this, and so we're kind of coming at it, you know, hoping to give you guys a bit of a sort of an overall, a bit of a snapshot and a speedy catch up on all the things that we've really been learning over the last sort of 12 to 18 months. And I do think that all that, the idea of chronic pain, understanding chronic pain and really educating patients about it is really key to what to making a good impact and a good therapeutic relationship. So I will so I'm going to try and sort of present a little bit more of a sort of case-based approach, really, kind of how to actually how to actually go about things in general practice. So as Jo said, the title of our presentation is really that it's not, you know, trying to make endometriosis and chronic pelvic pain a little bit less daunting. So I guess the way that I kind of try to make things less daunting is to try and sort of have an approach, a general place to begin, and sort of some steps to kind of work through. So so this is just some suggestions, really. So here's a little structured approach. So if we look at a case, and this is a real case, Tegan, who was age 17, she came for her first visit to meet me. She reported having painful periods since menarche when she was 13. She'd often described missing school 2 or 3 days a month. She dropped out of school in year 11 to do a hairdressing apprenticeship because she really wasn't keeping up. She had been diagnosed with anxiety and started on sertraline by her GP elsewhere, and was seeing a psychologist fairly regularly. She did report having low mood, but she hadn't got any suicidal thoughts at the moment, but she had got some past cutting scars. She'd never been sexually active. And really what had prompted Tegan to come in was that her mum had made the appointment, really, because she'd had 3 presentations to the emergency department in the last 12 months with period pain, severe pain, vomiting. But then she'd also she'd had a severe pain episode that was not associated with a period. And she'd also been experiencing new onset kind of chronic headaches and nausea and fatigue. She'd had investigations done in the emergency department, which had included bloods, which were normal, a pelvic ultrasound, a transabdominal pelvic ultrasound, which was normal, and she'd even had a brain MRI, which was normal. She'd been started on Yaz 4 months ago, which had reduced her menstrual period pain a lot. But she was really confused as to why she was still getting some severe abdominal pain with nothing showing up on the scans. And she was really worried that something was very wrong with her, but that the hospital had told her nothing was wrong with her and that she should go back to see her psychologist. She also felt her mum was really angry with her, and her mum was in tears in the consultation, saying that she felt really lost and had no idea what to do next, you know, from here to help Tegan. So, where to start with that fun consultation? So, it kind of is a little bit, this is an experienced gynaecologist who manages endometriosis and pelvic pain, and she gave a talk and described it as being everything, everywhere, all at once. And it is kind of like that, which is why I'm trying to kind of break it down into a little bit of a more structured step-by-step. Because after hearing all of that story and that consultation, who's feeling tempted to recommend a referral that she needs a laparoscopy and off to see the local gynaecologist, which may actually provide a very short-term solution in terms of getting them out of your consultation room, but really probably, as Jo has mentioned, probably isn't really going to be the best kind of approach. So what else have we got? What are our other options to try and manage this? So the structured approach I've kind of outlined is kind of is listed there, and we'll talk a bit through each of those things in turn. I've put examination kind of, you know, as doctors, we're always, and, you know, health practitioners, we're always very used to kind of doing sort of history, examination, investigations, and then management. But examination, you know, really does sort of, there are some benefits, but that there also, it may not always be required, or just a limited examination, as we'll look at. So I think Jo's already talked very well about the importance of patient storytelling. There's a lot for them to get off their chest, and as Jo said, sometimes actually giving them the time and space to explain everything and describe everything is important. Sometimes it comes out very neatly, and people will bring in sort of, you know, lists of symptoms and even chronological orders of things. Sometimes it all comes out as a great big tumbling sort of chaotic dialogue. But it is important to allow that talking, allow them to say what, you know, what things they've tried, what investigations and other things they've had done in the past. Those things are really helpful for you to know as well. They've often had quite fragmented care, as Jo mentioned. Often people have seen multiple practitioners and lots of different care providers, naturopaths and other people as well. So it's good to try and just sort of try and put it all together. As Jo's described very well, it really can be quite complex with sort of, you know, obviously periods can be quite sort of, you know, fundamental to endometriosis and pelvic pain, but not always. And so, but sort of describing those in some detail is useful, trying to work out, you know, where the pain fits into the period cycle, how much bleeding there is. If there's very heavy bleeding, then that may need managing, you know, in its own right. A little hot tip, that premenstrual spotting often does indicate endometriosis. So yeah, people describing a few days of light spotting before their period starts, particularly if that sort of has just started occurring in line with an increase in pain, that's very suggestive of endometriosis. The bladder and GI symptoms, as Jo discussed, you know, is that whole idea of all the organs in the pelvis are very close together. With activation and inflammation, then often they become sort of overlapping symptoms. Constipation exacerbates all causes of pelvic pain. And I think the food triggers, as Jo said, were quite, so often these people are quite sensitive, and things that sort of stimulate the bowel a little bit, lactose or gluten or certain, you know, salicylic acids and things, they'll often get quite symptomatic from those. And often recurrent UTIs. I often see women who are presenting that have been, you know, diagnosed with recurrent UTIs and symptoms, but often when you track back, their cultures have been repeatedly negative. And in fact, this probably represents more of that sort of, activated pelvis and kind of central sensitization. And then the systemic symptoms that I think Joe described all of those very, very well, and both the sort of as a cause and as an effect of pain. Sexual function and fertility are sort of more specific, I guess, to pelvic pain and endometriosis rather than some other chronic pain syndromes. And definitely having painful periods and a sore vulva and dysuria and things can have a huge impact on your confidence in developing intimate relationships. There's also an overlay of the whole sort of discussion around fertility and people's plans for fertility or not. Some people may feel fearful that they won't be able to have children. That's quite common, but I also have had people who felt very much, they felt pressured. People always tell them that they should get pregnant. That'll be the way to fix their pelvic pain. So it's complex. It can be very useful to use some screening questionnaires in order just to try and actually record some of the history and current symptoms in a more sort of coherent way, establishing some baseline function and really try and help define the problems and sort of try to sort of work towards setting some goals. So there are some questionnaires and that you will find useful. There's the Pelvic Pain Foundation has a great questionnaire that's a very detailed history and symptom record. You do need to be a subscriber to access that, but it doesn't cost very much and it's a very excellent resource, and they have lots of education seminars and things. Raising an awareness tool for endometriosis called the RATE is an online endometriosis screening tool. And all of these things, patients, you can either get them to complete in the consultation with you, and sometimes if you're not quite sure where to go with a consultation, it can actually be a really useful thing to work through one of these questionnaires together, because it does provide a bit of a structure for getting out all of the history and all of the symptoms of overlapping pain and central sensitization. But otherwise, patients you can get them to do them at home and they can email them back to you or print them. A DAS, I think, is very useful. We do that pretty much routinely on everyone that we see, because, as Joe's mentioned, depression, anxiety and stress all really do impact both as cause and effect of chronic pain. And the Pelvic Pain Impact Questionnaire is quite a specific questionnaire that's been developed. So these little QR codes, the black one is a link to the RATE tool, and the red one is a link to the PPIQ questionnaire. The PPIQ you can also repeat serially, as you can with the DAS, I guess, but the PPIQ is more specific for pelvic pain, and that can be really helpful to see whether you're actually making things better. So this was Tegan's PPIQ that she completed. So really it's just to kind of give you an idea of what's on there and sort of symptoms. So some of them are about the central sensitization and the energy, mood, sleep, the overlapping symptoms, that hyperalgesia that Joe talked about with that difficulty wearing tight clothing, and then the impact of ability to engage in normal function activities. And then the questions at the bottom, which are kind of optional, which is more about sort of the people's ability to use tampons and sexual function, that give a guide as well, I guess, to how much activation there is in the pelvis, in the pelvic musculature. So as I mentioned, goal setting I think is very important. I think it helps to guide the direction of the consultation, the direction of the management, and try to bring it back to really sort of dealing with what the patient's concerns are. And sometimes people are very easily able to establish that. Sometimes they need a bit of direction. So sometimes I find it helpful to ask people, what would you most like to be able to do that you can't do now? And that sometimes helps work out some goals. So Tegan's goals were, she said she really wanted to have less bleeding and less pain because it was really disrupting her every month. And she also, her other concern was that she was worried that something was seriously wrong with her and that no one had found it yet. It was also important to consider mum's priorities as well. She was sort of very involved with Tegan and and she had, been involved in arranging the consultation, and there was also obviously a complex sort of relationship between the two of them, so that was good to get them to hear each other's priorities. She was concerned about Tegan's mood and mental health and about how much school and now TAFE she'd been missing. And this, I guess, sort of comes down to this idea now of building this therapeutic alliance. And as Jo said, it was really about sort of building that relationship, giving people time to talk, explaining where you're coming from, and trying to get on the same page. And this is probably way more useful than any particular medication or any particular sort of surgery or intervention or referral. It's this idea of validating their experience, validating that this is a complex, multi-dimensional kind of condition that's not going to be fixed quickly, but also providing some kind of optimism and that you do have a plan for how you guys are going to be able to work through some of this stuff together. And as Jo's described very, very well, the importance of pain education and a lot of the resources available for that. Another really helpful resource is specifically around pelvic pain and endometriosis is really this, it's on the Pelvic Pain Foundation website, and there's a pelvic pain brochure, which I'm just going to show you now. So this is so you can access this online, and I'll just link you to the website in a second. But I just find showing people sometimes this on the website can be incredibly helpful in building that therapeutic relationship. To be able, it may be the very first time that people have seen all of their list of their chronic unfathomable symptoms that have baffled everybody and that they find overwhelming, and for them to see that they're all written down on a page together and that other people have experienced this and that this is not so mysterious that it will never be solved, that these are all, things that are interrelated and that they can be, that there are managements and strategies for these. I've actually had patients cry when they've seen that because they have felt so validated that all of the unusual, vague symptoms that have been dominating their life, sometimes for many years, actually, come together, and actually it looks like you may be the first person that's going to be able to actually help them put it all together. Just going to try and link through to the Pelvic Pain Foundation website just to show you, and I do think it's definitely worthwhile saving this to your favorites. So I just often do open this up with patients. I show it to them and I show them this and say, look, there's lots of information on there. There's information from health professionals and things, but for women and assigned female at birth. And then you can just scroll down and show them how there's information on all of these different things. Often around irritable bowel can be really helpful. That's something that often is common and takes up a lot of time to discuss in the context of lots of other things going on in the consultation. And these great resources. So that's where the pelvic pain booklet that I just showed you the front cover of, and also I'm going to come back to these stretches. In fact, I might even just show you them now so I don't have to come back to them later. But some lovely stretches for managing, relaxing the pelvis that people can just do at home. So a really nice resource for people to have access to. So in terms of clinical assessment, as I've said, examination is, I've put lots of question marks after the pelvic examination bit. I think it's useful to do a blood pressure, a height and weight, BMI. The pelvic examination, I think it's really important to consider, what are you actually looking for if you're going to do a pelvic examination on somebody? They may well have a lot of, hyper, sensitization and allodynia. So I think it's important to always give people the option to defer the examinations. Sometimes I've really noticed people shrinking away or, undermining good progress that we're making in the consultation sometimes when the concept of doing a pelvic examination comes up. So, and as Jo said, it's important to be trauma informed and give people the option to defer the examination unless you feel it's really important. And if so, then explain why. A hot tip though with that and is that if you are going to do a vaginal examination, then in fact sometimes the most important thing to do is actually not really examining the uterus and the the adnexa, but in fact actually turning your fingers around and feeling against the lateral pelvic wall, and sometimes actually getting them to push their thigh against your hand, your other hand, and getting them to push against it. And then if you push your fingers against the lateral vaginal wall, the obturator internus muscle stands out against the side of the wall there. And if that actually reproduces their pain and causes quite significant pain, then that's a very, very strong indicator that a lot of their pain is coming from the pelvic muscles. And sometimes that can be incredibly helpful, used in the right person at the right time, to show them, in fact, that the pain that has been unexplainable and the pain that has been crippling them and really stopping them from doing a lot of things, worse with exercise, very painful during sex, often can actually be reproduced, and that indicates that it actually is a muscular pain, which makes it a lot less scary and a lot more positive when people see that they actually do. They're much more used to being able to feel empowered to manage muscular pain. However, it may certainly not be an appropriate thing to do in someone such as Tegan on the first visit, and it may well be much better off left to a pelvic physio to do some external releases and then gradually working towards those more invasive examinations if required. Again, blood tests and urine screening, STI screening, cervical screening and things, really just considering, do they fit in with the clinical picture? What are you hoping to get from them, out of them? But certainly people with heavy menstrual bleeding should have their iron checked. All those little things can sometimes build, improved well-being if you manage things like iron deficiency. And then imaging, I won't talk too much about this because it can, all of these things can be whole sort of lectures in themselves or talks in themselves. But a transvaginal ultrasound or a transabdominal pelvic ultrasound is really only useful to exclude other pathology. So, and sometimes you do. I mean, I have certainly found some big teratomas which have caused pain. Sometimes fibroids, are causing pain, and pressure on the bladder and things. So it is important sometimes to exclude other things, but they're definitely not very sensitive for endometriosis. Even a DIE scan, a deep infiltrating endometriosis scan, which is usually done at a specialist centre and requires bowel prep usually, and the probe is in the vagina for quite some time. It usually is useful if you're referring on really to a specialist gynaecologist for workup for a laparoscopy, or if there's a lot of bowel pain. Sometimes I find a DIE scan can pick up some involvement of the bowel, or if you are really not making headway with managing pain with your other strategies. And MRI can sometimes be used really in a specialist setting before surgery. As Jo mentioned, we're really trying to reduce the number of laparoscopies. Definitely this idea of a look-see laparoscopy is really old-fashioned. Really, if somebody's going to have a laparoscopy now, it should be done once by the right surgeon, and really with them knowing what they're going to find in there so that they can involve other surgeons and other things as appropriate. So it may involve having a colorectal surgeon there as well, or a urologist if there's involvement of ureters and things. So management options, there's lots of different options, and it's important not to overwhelm people. I think it's really important to focus on the patient priorities, and that you don't have to fix everything at once. Just sort of start with a couple of goals and set some realistic time frame expectations. So looking at different options that we're going to, then, you know, things take time. So managing dysmenorrhea. So that was one of Tegan's requests, was that she really wanted to be able to manage her pain more. And so it very much, all of these options depend on the individual person, what suits them. Don't neglect the importance of good information about simple analgesia, because it often can be very effective if taken in the correct way. And most people know to take, you know, they often will have been taking some naprogesic or some ibuprofen, but they won't necessarily have been taking it in the most useful way. So it really is helpful if they started a day or two before their bleeding actually starts. And so those people that I mentioned who have some premenstrual spotting, that's the time to actually start their anti-inflammatory for more effect. People can use it for up to 7 days, usually more like 4 or 5 days. Obviously take it with food. Sometimes you can use a PPI cover if people are getting some gastric symptoms. There are different options, but the oral mefenamic acid, naproxen, diclofenac, ibuprofen, and a little hot tip that I just discovered recently from a patient was that you actually can get Ponstan on the PBS. You can get 50 tablets with 2 repeats indicated for dysmenorrhea, which certainly does bring down the cost, particularly if someone has got access to, you know, a healthcare card and cheaper medications. Consider long-acting non-steroidal anti-inflammatories. I do find them really helpful for people who just find it hard to take tablets frequently. And PR options can also be very helpful if people are getting gastro side effects particularly, and they're often longer acting. Really avoid opiates. I just really haven't really had to use them very much. It's been amazing. I was really worried that we would end up being involved in prescribing a lot of opioids, but it really hasn't been a big issue. Sometimes you will inherit patients who are already on opioids. And I think it's important for the Therapeutic Alliance not necessarily to just say that you won't prescribe anything, but really to explain, again, some of that pain science and how really, you know, treating with opioids really isn't really managing what's going on, and in fact can aggravate those pain pathways and interfere with those, and also obviously exacerbating constipation, and they do have sort of a tolerant and addictive potential. So trying to at least reduce dose escalation and then working towards dose reduction if needed. So cycle suppression, so that can be very, very helpful, and it probably really is a bit of a cornerstone really of managing painful periods. We all know this. The other good thing about it is that it stops ovulation pain, which often can start to become an issue for people with chronic pelvic pain. Even the act of ovulation tends to trigger their pain as well as they're getting their menstrual pain. It's really important to encourage or to discuss about skipping the sugar pills, the inactive pills. There's really no benefit in having a withdrawal bleed. All it's going to do is cause bleeding and inflammation. So really trying to skip stay on the active pills and skip a bleed for as long as possible. There's very good safety data on this for over 12 months, and so, you know, there's no concern about it at all from a medical point of view, but it's really important. Patients often do think that there could be something wrong with doing that. Basically, any combined oral contraceptive pill should be effective at doing this. Sometimes the lower strength, the 20 microgram ethinyl estradiol pills may not be as effective for being able to skip withdrawal bleeds. And so if you remember, Tegan is on Yaz 20, which is a 20 microgram pill. Drospirenone, the 4 milligram formula progesterone only pill, which is sold in Australia under the brand name Slinda, is extremely useful. It can be used in a whole host of people who are not able to use estrogen, they don't tolerate it, or they've got migraine with aura, or smokers, or previous VTE, or family history of VTE. In all of those people, Slinda is safe. It provides very similar effectiveness at stopping ovulation and probably better cycle control than a lot of combined contraceptive pills. my little tip, I haven't said it's a hot tip because it's really just my anecdotal tip, is that if you start Slender on the first day of the period, it actually seems to reduce the chance of them getting unmanageable progesterogenic side effects. Sometimes if you start it later in the cycle, they can really get quite a lot of bloating and tummy cramping and moodiness and things because they've got their own progesterone from their luteal phase, and then you go and dump a whole lot of more progesterone on top of it. So I often do try and start it with the first day of the period, which usually will help block even that first ovulation, but definitely advising that it will take about 3 months to get bleeding control. Breakthrough bleeding is very common in the first 3 months. So this is where that therapeutic alliance comes in, because you're really wanting them to buy in. You're wanting them to trust you, that you know what you're doing and that this is a good established option that they may find helpful, but they're going to need to hang in there for a little bit and trust you. There are also other options. So Implanon is easy and cheap. It's just the bleeding pattern sometimes is a little bit harder to predict, and sometimes that means people will get unplanned bleeding and pain. Gynaecologist Visan is extremely effective and well tolerated in my experience, but it is expensive and it's not contraceptive. It's about $69 a month. And then there are some new oral GnRH analogues that have also got some other ingredients in there. A new one that you might have heard of called Raico. I've basically got very limited experience with that to date. I've got a couple of people who've just started on it recently, one for fibroids and one for endometriosis, but it is expensive. It's about $132 a month. There is an application going through to the PBS to have it subsidised, so we'll see. So the other thing, of course, that you're probably aware of is using Mirena to help with managing painful periods and bleeding. It's extremely powerful at reducing menstrual bleeding, about a 90% reduction in bleeding, and along with that usually there's a big improvement in pain. Although it does take time to be effective, and people really should expect persistent, especially it seems often people with endometriosis will get quite a bit of settling in pain, cramping, and breakthrough bleeding in the first, up to 6 months. Sometimes I do find combining it with cycle suppression for the first 6 months or even long-term ongoing. So can be really, really helpful because they stop ovulating, they get much better bleeding and cramping control earlier with the Mirena if you do cycle suppression as well. And then sometimes you can actually stop the cycle suppression later on and they're okay for a couple of years with just the Mirena on its own. And so I would often use Slender or Implanon to do that. You may have found that quite a lot of women that go for a laparoscopy will have a Mirena inserted at the time. I generally think that is a really good practice because it can always be removed, but if it is put in at the time of laparoscopy with their consent and explanation beforehand, of course, then it does get over the need of possibly having to have another procedure done to get it put in. You can certainly insert an IUD at any age. I often have put them in 17-year-olds. I have put them in women who've never been sexually active at their request, but there is also the option of insertion under sedation. So a little bit more just about managing dysmenorrhea. So we've talked a bit about the medication role, but also about this idea of self-management, really trying to increase people's capacity to feel they know what to do to help themselves. A lot of people will already be doing all of these things, but encouraging them to use heat packs, rest, as Jo said, sometimes just reducing activities, especially around the time when you know you're going to be having a painful period. The pelvic stretches that I showed you can be really helpful in just reducing that tightness. I often use the analogy for patients of people with migraine will often see a physio or get a massage or use a heat pack on their neck to try and release some of the tightness because they'll get that from their migraine. Exactly the same, people with painful periods will often get a very, very tight activated pelvis, and that the stretches can really help to reduce that, and it is very, very effective and very safe. There are some great tools now available. The Quendo app was developed in Queensland Endometriosis group, the PPFA website and the booklet that I showed you. And the importance of team referrals. So yes, physiotherapy I think is really crucial, and can be just a total game changer. It's often something that people haven't tried. Even people who've had endometriosis for a long time may have had one or more laparoscopies. They may already have a Mirena in, they may already have different things, but very often they've never seen a pelvic physio. And that can really be sometimes the only thing, the only useful kind of thing that I think I'm adding, but it can be a very useful thing. And then, as we talked about, definitely considering involving a gynaecologist, but trying to pick one who's got an endometriosis subspecialty if their period pain isn't being managed in primary care. There's no definite time limit on things, but I guess if you're not really improving things kind of around about the sort of 12-month mark, or if it's more severe earlier, would be time really to be considering referring on. So the idea of this feeling bad, the sensual sensitization, the fatigue, the low mood, the sort of chronic worry, poor sleep, all of those sorts of things. And it is really important to address those, acknowledge them, and try to sort of work out some ways of trying to make people feel better. For this, because it really helps managing pain. I do use a lot of amitriptyline, and there's some really helpful resources on the PPFA website. There's a little handout here that actually is specifically about amitriptyline and its use in pelvic pain. And it goes through it gives information, side effects, how to start it and everything. It's a patient handout, and I think that's very useful and reassuring for patients to see that even though it is an antidepressant, that we use it a lot for pain syndromes. And explaining, again, tying it in with that concept of central sensitization and pain education, as Jo explained. There can be a little bit of a concern if somebody's already on a high dose SSRI or SNRI, particularly if they're also using opioids. But usually a low dose of an SSRI and a low dose of amitriptyline would be safe to use, and I've had many psychiatrists validate that as well. So antidepressant medications, if you're thinking about starting one off, sometimes things like duloxetine and sertraline probably do have a better effect on central sensitization and pain modification. There is some interest in testosterone therapy for improving well-being in people with chronic pelvic pain and endometriosis, but I myself have little experience with that to date. The self-management, again, the relaxation tools, there's some great links to a relaxation audio on the PPFA website. Great information on the apps. There's a Quendo app, there's a Matilda app. All of these have been developed for use by a person with pelvic pain or endometriosis. The Endometriosis Australia actually provides support and one-on-one mentorship for people, which can be really, I've had patients really enjoy that experience. Just trying to build their own capacity, work out where exercise fits in, when do they have their downtime, when does exercise help, managing sleep and patient-specific activities. What are some things that make them feel better? Yoga, drawing, a hot bath, all those types of things. And then a team referrals, involving a psychologist, particularly if they've got an interest in chronic pain or endometriosis, and there are ones around and more coming out of the woodwork with more awareness about endometriosis. And as Jo said, exercise and involving an EP can be very helpful. So managing a lot about the non-menstrual pain, muscular pain, the bladder and bowel pain. And again, I find amitriptyline useful for that. Sometimes, definitely the pelvic physio can be super helpful, really also helpful in using TENS machines and things, which can be very helpful for the non-menstrual pain. Sometimes that type of pain is managed much better by TENS than by medication like NSAID. So it's the pain that doesn't get fixed by NSAID sometimes can be more that sensitization pain. And then, as I said, referring on, and definitely there are complex pelvic pain clinics at the Royal Hospital for Women, and there's some private options as well. In the city, there's the Wiria Clinic, which has also got a bit of a pelvic pain focus. So some useful resources that I've just kind of briefly mentioned are all there, and I recommend them all highly. And then really, I guess, trying to sort of make a little bit of a plan towards the end of the consultation. There's an idea about sort of leave with more than talking. So if you can actually write down a few things, a few resources, print out a few things or email people things, maybe some the stretches, a little brochure that I showed you. Definitely if you're starting off some medication, then some information on those, or even there's some medication advice on how better to use their anti-inflammatories. That pelvic pain booklet, either showing them where to access it on the website or printing it off for them. And sometimes if they've completed some questionnaires, then they can be really useful resources for the patient to have, to take to other providers, care providers that they may see, because it really does summarise all of the story quite well, and a useful thing for them to have, and making a plan for a next appointment so that they know that you're interested and that you do want to see them again, because they're quite used to being dismissed and sort of people wanting to get them out of their consultation room and into someone else's. So with Tegan, what did I do with her? So I listened to her story, tried to help work out some goals and priorities, which was less pain, less bleeding, and reassuring her, trying to work out about the pain and how a lot of her pain probably was to do with central sensitization and muscular activation in the pelvis, which made her less fearful. The idea of getting on the same page with the pelvic pain booklet and pain education. With medications, we discussed about how to use the pill better, and we talked about changing pill to something that may give her better cycle control and be able to skip the inactive pills. She was quite concerned about mood effects, and because she was okay on the Yaz, she was reluctant to change. So we said to stay on it but continuously cycle it for the next 3 months until we were going to catch up again. And we also talked about increasing the dose of sertraline. We gave some tools around the self-management, encouraged her to have a look and download the Quendo app or Matilda app. And also there's some specific information and advice for mum on the PPFA website that's about managing a young person or living with a young person who's got dysmenorrhea and endometriosis, pelvic pain. So we made a plan to follow up in 3 months, but sooner if she was getting persistent breakthrough bleeding, and then we might look at changing the pill. And so I guess in summary, endometriosis is a complex chronic condition. It's not really about fixing the problem. Trying to set some goals can be really helpful to try and guide the whole process, the consultation, and then the ongoing contact with that person. And having a team approach and really encouraging people to kind of see it like that. We're building a bit of a team to help manage this, and obviously the person themselves is central to the team, and really the focus on building their resilience and their control and their decision making. So thanks very much. And if you are interested in providing more endometriosis or pelvic pain assessment and management in your practice, then we would really love you to let us know. We are really keen to help support as part of our grant. We recognise that we cannot see every person with pelvic pain in our health network, and so we're really super keen. Our role will be more about trying to actually improve capacity within our whole region in primary care. So we're really keen to help your practice. We've got lots of resources. We've sort of worked out a bit of a way to manage appointment scheduling. We've got some good advice about education and training, and we're happy to provide training in IUD insertion and other things if required. And some good links to some other multidisciplinary team members and things that we can connect you in with. So thank you very much for listening.
Thank you both so much. We might go through some of the questions that came through in the Q&A now. So the first one is, I have a patient in her late 30s with known history of endometriosis, managed previously by a gynaecologist who now presents with infertility. Would this patient benefit from being referred back to her previous gynaecologist, or should she be referred directly to a fertility specialist for IVF, for example?
I mean, I would have thought maybe I'd recommend that patient go and see a fertility specialist and have all the workup done for subfertility. And I mean, we do know, and I'm sure Beck, you could talk to this too, that if they do have endometriosis, like if they have a laparoscopy and they do find endo in this patient and they excise what they can see, that really increases a woman's chances of conceiving. I think it's increased, especially in that first 6 months that follows that laparoscopy. But yeah, I personally would refer them to a fertility specialist first. I don't know about you, Beck.
Yeah, I think that, I mean, I saw that question actually come up quite early on, and it's a really complicated one, and probably too complicated for us to get to really answer properly, I think, because it really, you know, you could speak to two different people and they'd have two very different opinions. There's no doubt that laparoscopy also, and particularly if there's ovarian involvement, if you have a surgical procedure done on an ovary, then you are really going to reduce that ovary's capacity to function. So it would usually involve things like checking AMH. But I agree, Jo, I'd refer on to a fertility specialist to get that viewpoint first. And in fact, sometimes people would even recommend, if it was very severe endometriosis, particularly if the patient was getting a bit older, maybe in fact to actually do egg collection, or even and freeze eggs or embryos, then go and have a laparoscopy and pelvic surgery, and then try to you've got the embryo to use. Yeah, I've got a few people who we're having these conversations with at the moment, and they often really do respect having an independent person, because often they've seen the fertility specialist and the endo-gynae, and sometimes they can't agree. So sometimes it's nice for them to be able to come back and just talk through the issues with a non-expert who can just try and help them work out what their goals and priorities are.
Great, thank you both. Next question, is there any information on endo test use in Europe?
Yeah, I saw that one, and we're not using it in Australia from what I know. It's not really validated yet as a test that's reliable for us to use to diagnose endo, but I'm sure there are lots of people out there trying to develop a blood test that will be able to help us diagnose endometriosis, and won't that be great if we can find one?
Thank you. Next question is, any courses or conferences that you'd recommend to upskill in this area?
I mean, Beck, I would have said that the pelvic pain conference that is held annually by the PPFA is really excellent. We went last year as part of our upskilling for this, and it was so good, so educational. It's held, I think this year it's late August, and it's for a weekend in Adelaide. The speakers come from all over Australia. It was fantastic. I really got a lot out of it. But I would also recommend, if you don't want to travel, of course, that the RANZCOG have an endometriosis online learning course that is free, and that is really great and will certainly help your clinical practice. And the Explain Pain one was the other one, which, as I said, I haven't done, but I'm planning on doing it now that it's paced at your own pace. But everyone who's done it has gotten so much out of it.
The only other things I'd add to is Susan Davis, who was the gynecologist who kind of set up the PPFA, she did actually talk at Health, Ed, Women and Children's last year, and she does talk around the place from time to time. That talk may be on the Health Ed website, but as you can see, I've been heavily influenced by her if you listen to her talk, because the way she approaches things has just kind of really helped me in my practice, I think. And the other thing is that there is a New South Wales pelvic pain network as well. So we can forward on sort of some, a link of how to get in, how to make contact with that. But as I said, if people are interested in kind of providing a little bit more of a focused, and upskilling on it, then we're also really happy to help and include you guys, share with you the resources and the networks that we've learned about.
Great, thank you. Next question is, any tips for patients with chronic pelvic pain who don't want to use hormonal therapies?
So I guess, as I said, that, I talked a bit about the using anti-inflammatory, non-steroidal anti-inflammatories, different types, different formulations, how to get the most out of them. Tranexamic acid can also be used to reduce heavy menstrual bleeding, and sometimes that can reduce pelvic pain if you reduce the heaviness of bleeding. Sometimes a Mirena, it just depends on how you can kind of talk around that with the patient. But sometimes if they sort of understand that they are still ovulating, they're still on their own sort of hormone cycle, and it's a very low dose, localized dose of hormones. Sometimes people who are fearful of other systemic hormones or haven't tolerated the contraceptive pill or things like that in the past will actually be, with a little bit of support and therapeutic alliance, be happy to trial something like a Mirena, but they will need a bit of support because all these things take time to work.
Thank you. 2 more questions to go. Any comments on using Clara or Zoli?
So, the thing that's different about Clara and Zoli is probably really that they've got a different type of estrogen in them. So they use, instead of ethinyl estradiol, they use estradiol. I don't think there's any data really on, is there a difference in terms of effectiveness at reducing dysmenorrhea? There's certainly no head-to-head studies between different contraceptive pills looking at that. Both of those pills generally are pretty good at being able to skip bleeds and reduce menstrual bleeding. So Clara I really haven't used for years. It's a complicated pill to use. But Zoli, Zoli, and the other one that's new on the market too, that has a natural or body identical estrogen, is Nextstellis, which has estetrol in it. And look, there's no real evidence. They all provide quite good bleeding control, but I don't think there's really anything to separate between them for endometriosis or pelvic pain.
Thank you. And the final question is, how do we contact you if we want to upskill in this area in our practices?
What a good question. Jo, what do you reckon?
Thank you. We would love you to contact us. I think maybe if you pass your details on to Lauren and Elise, and they'll send them on to us, then Beck and I can work out a time to catch up with you and talk you through things. Yeah, we'd love to do that.
Yeah, if I guess we were kind of thinking if there was a group of people we could possibly run a smaller sort of workshop with maybe a pelvic pain physio and some other people there, and but then we also possibly do have capacity to even come into a practice and sort of help upskill a whole practice, because it can be very useful to get nursing staff and sort of a whole practice kind of on the same page. Yeah.
Well, thank you both so much for your presentations tonight. It's been really insightful.